Thank you all for joining. I would like to discuss my master's thesis, the ROSIM study about virtual reality and dry lab robotic suturing training for novices. So with the expanding use of robotic surgery, we must protect the patient for the surgeon's early learning curve by using adequate training programs. So in the Netherlands, the LALABS 3 trial was launched by the Dutch Pancreatic Cancer Group, resulting in implementation of robotic Whipple procedures nationwide. And thereafter, Leah and Maurice conducted the Learnable training program using both VR exercises with the simulator and also dry lab training in biotissue. Although many studies aim to create a robotic training standard, no consensus has been established yet. Various studies investigated VR training with the Mimic DV or the DVSS, but also the conventional dry and wet lab training in inanimate and animal models. However, the comparative studies about VR and dry lab training investigated basic tasks, and no studies used biotissue nor objectively assessed the surgical performance with force measurements. And also VR software is rapidly developing, and the new SimNow simulator has not yet been compared to dry lab training. So therefore, the primary aim of our study is to examine the effect of the SimNow on robotic suturing by novices, and secondarily, to evaluate the experience of the participants with the new SimNow system. So we conducted a randomized experimental crossover trial, and 20 robotic novices were practicing with both the SimNow as VR training and in the suture pad as dry lab training. And thereafter, a robotic suturing exam was performed with hepaticojejunostomy in biotissue, as you see on the picture. All robotic novices were randomized in 2 groups of 10 participants per group, one group starting with VR and the other starting with dry lab training. And prior to the experiments, 3D vision was tested. The primary outcome was surgical performance according to the Objective Structured Assessment of Technical Skills, the OSAT score, and secondary outcomes were force measurements and procedure time of the exam. Also, participants' demographics, including baseline experience, were included, and the participants' personal opinion on the feasibility of both systems. So the OSAT score is a subjective grading tool validated by Bergmeier et al. And includes different grading aspects, as you see in the table. And for our study, 2 raters scored the exam according to the OSAT score. The force sense system measures forces on tissue per repetition of 20 milliseconds. And the outcomes are average force. So that's the average of the whole exam with all repetitions included. And also the non-zero force. So the average when forces are above 0. And maximum force and impulse. And the latter 2 are the most important, as force on tissue is associated with tissue damage when exceeding a benchmark of 4 newtons. And because we want to give an accurate prediction of potential tissue damage, we also calculated the average force per repetition of both groups. So data collection took place at the Amsterdam Scale Center and the OR of the Amsterdam UMC. Participants received instructional videos prior to the day and also on-site a brief instruction, and they all used the same instruments, a scope and 2 arms with needle drivers. The intervention group started with VR training with the SimNow for 30 minutes, and the control group with dry lab training in the suture pad for 30 minutes, and followed by a questionnaire and a robotic suturing exam. And thereafter, the participants were crossed over to the other training modality, also followed by a questionnaire and a robotic suturing exam. The VR training included 15 minutes of practice with the running suture exercise to practice needle handling, as you see on the picture on the left, and 15 minutes of knot tying, as you see on the right. Dry lab training consisted of 30 minutes interrupted transcutaneous suturing in the suture pad. And finally, the exam. The exam included 15 minutes to perform an hepaticojejunostomy as far as possible in biotissue. And also during these exams, the data was collected. As you see on the upper right corner, all the exams were recorded and the videos were subsequently rated by the raters. And on the left, you see the force sense system for the force measurements. The sample size was based on population proportion, as no literature existed on studies including both OSAT score and force measurements. There are 1,200 surgeons in the Netherlands and 400 residents, of which 50 residents in the Amsterdam UMC. Therefore, with a population proportion of 1%, you would need 16 participants to have a 95% confidence interval. And with 20% failed, we expected to need 20 participants. We compared the OSAT scores and the force measurements between groups. The normally distributed continuous data of the OSAT score was analyzed with an unpaired t-test and presented in means and standard deviations. And the non-normally continuous distributed force measurements were analyzed with the non-parametric man-Whitney U and presented in medians and interquartile ranges. The data of the baseline demographics was categorical and analyzed with a chi-square and presented in frequencies and percentages. And the qualitative analysis was scaled. So with the Likert scale ordinal data, we presented these results in means and standard deviations to enhance interpretation of the effect size. And all analyses were performed at SPSS with a p below 0.05 considered statistically significant. So in December 2022 and January this year, 20 robotic novices performed 40 hepaticojejunostomies. And no difference was found between baseline characteristics. The mean age of all participants was 31 years old, 7 males, 13 females, and the median level of residency was the first year, and 3 participants were medical doctors not in training. Regarding the open laparoscopic and robotic suturing experience, there was also no difference between groups, and none of the participants had any experience with robotic suturing. The only experience with the robot reported was changing instruments as an assistant during live robotic procedures. So the OSAT score, the exams were scored by the raters, and we created a combined OSAT score, so the average of both raters combined. And there was significant inter-rater variety, and therefore we did not only assess the combined OSAT score, but also the OSAT score per rater. And the combined OSAT score of the second exam was significantly higher in the intervention group, so after VR followed by TriLab, and as well as the OSAT score of the second exam when rated by rater 2. Initially, the means of each exam were used to calculate the average forces for the whole group, and there were no significant differences found between these outcomes. And therefore, I would like to continue to our sub-analysis with the force measurements per repetition, which we presented in graphs and histograms. Here you see the average force of the first exam presented over time. So the 900% on the x-axis is the 15 minutes the participants had to complete the anastomosis, with the intervention group in blue and the control group in pink. And as you can see, force peaks frequently exceeded the 4 Newton threshold, and also the average force of both groups significantly decreased over time during the first exam. On the left, you see the frequency per force on tissue, and you can also see again that both groups frequently exceeded this 4 Newton threshold. The maximum forces measured for both groups were similar, 10.2 Newton. For the second exam, you see that forces also frequently exceeded the threshold, and interestingly, the average force of both groups significantly increased over time. And as you can see in the histogram, is that the control group included more repetitions with forces below the threshold, but the control group also exerted the highest maximum force with 152 Newton compared to 20 Newton in the intervention group. So for the baseline demographics, we performed a univariate analysis, which showed that experience as an assistant in robotic procedures and experience with the Da Vinci system in general were correlated with a significantly higher combined OSAT score for the first exam. And therefore, we excluded the participants with one of these experiences and performed a sensitivity analysis, which did not show a difference between the groups for both exams. The qualitative analysis was performed with the questionnaire, in which 17 out of 20 participants recommended to include VR training with the SimNow in a robotic curriculum, whereas all participants agreed on including TriLab training with the suture pad. 14 participants preferred to start with VR followed by TriLab training, and 6 participants preferred to practice opposite sequence. And training capacity and side effects were scaled from 1 to 5, with 5 is best for training capacity and 5 is heaviest for side effects. And as you can see, reality rate, didactic value, and feasibility for training scored significantly higher for the TriLab training compared to VR. And experience of disorientation was reported to be significantly worse with VR training compared to TriLab. Other side effects were similar between groups. So new aspects of this study are subjective and objective assessment of surgical performance and the use of biotissue and advanced suturing tasks. And also this study is the first to compare the new SimNow simulator with robotic suturing training. The results of the first exam show that VR with the SimNow is non-inferior to TriLab training regarding OSATs and force measurements, suggesting the SimNow to be a suitable alternative to train robotic novices at the beginning of their learning curve. But sequentially, the results of the second exam show a substantial improvement of surgical performance when starting with VR followed by TriLab, with a significantly better surgical performance in OSAT score, suggesting TriLab to be superior when continuing the learning curve. And this was also supported by the sub-analysis with the force measurements per repetition, as the control group potentially caused more severe tissue damage compared to the intervention group. And although no difference was between OSAT scores of both groups was found after sensitivity analysis, we assume that's because the sample size became too small after excluding the participants with experience with the system. And so far, only one study has investigated the new SimNow simulator for training of surgical residents yet. This study included 41 surgical residents who all practiced 33 VR exercises with the SimNow. They did a pre and post test, which was rated according to the OSAT score. And this study showed that surgical performance significantly increased after VR training with the SimNow. However, this study didn't compare the VR training with dry lab as we just did. So the SimNow has multiple advantages as it's more accessible and has less setup time because it only requires a surgeon's console and the SimNow backpack compared to the complete system with instruments, materials, and a trainer for dry lab training. And the SimNow provides personalized feedback and has lower costs. However, further development of the software is needed as the qualitative analysis showed that reality rate of feasibility was scored significantly lower compared to dry lab training. And also dry lab training still seems needed for continuing the learning curve. So surgical performance robotic novices is similar after single training with VR versus dry lab, and robotic suturing curriculum, including both VR and dry lab, should ideally start with VR. Also, future studies are needed to compare VR dry lab with only dry lab to specifically assess the added value of the SimNow and to finally conclude whether or not the SimNow could eventually replace dry lab training for robotic suturing. And this was my study.